Hi, good afternoon, everyone. So I'll be talking today about the Dementia Direct Enhanced Service, which affects primary care. But actually, I think it's the questions that arise as a consequence of this DES that impact the wider system, which I'll be discussing as well. So hopefully we can have as much of an interactive discussion as would be possible. So I graduated in 2000, I finished my VTS training, I should say, in 2009. And I chose to work for one of the worst practices in Greenwich because I never understood what makes a practice bad. And if you are a bad practice, A, why are you bad and what can you do to transform? And if you are serving 5,000 patients, what can you do to really truly serve those patients and improve their quality and outcomes? So I've been very, very fortunate. I've taken on different roles within the system. And my purpose for taking on these roles really is to allow me to have a better informed consultation with my patients when I meet them. So I can actually tell them about what the RCGP is doing or what the LMC is talking about. I don't have to blame a PCT. I can say, this is why the CCG is doing this because of this, and trying to empower patients to self-care where appropriate and refer when necessary. So just kind of giving a bit of background about dementia. So we know that nationally there's 800,000 people that are affected by it at present, and by 2050 it's likely to double. Yet as a primary care community, we're not great at recognizing, we're not great at supporting necessarily, and there's probably arguably things that we could do better. So it is a national priority, it's a Department of Health priority that as a system we are doing more for our patients who are either suspected to have dementia or do have, and more for their carers as well. And the recently launched Direct Enhanced Service asks us to identify patients who are potentially at risk of dementia, offer an assessment to detect for signs of those patients, refer when appropriate, and support the health and well-being of both patients and their carers. What it's specifically asking us to do is essentially do an audit in GP practice for all those patients over the age of 60 who have had coexisting cardiovascular disease, coexisting stroke, coexisting peripheral vascular disease or diabetes, people over the age of 50 with learning disabilities, people over the age of 40 with Down syndrome, in addition to people with a long-term neurodegenerative condition and anyone presenting with a memory complaint. So for 5,000 patients that I look after, that's probably going to be me doing anywhere between 300 to 400 extra screening assessments per year. And that is in a very, very small practice where we have 1.5 whole-time equivalent GPs and about 0.75 nurses. And already the system is at capacity. So the question is, how do we deliver this? That's with my GP hat. And what is the CCG going to do to enable this to actually not just be a tick box exercise, but actually try and improve outcomes for patients that have to go through this process? So what I then decided to do with my CCG hat, so I lead on mental health and business intelligence within the CCG, is to try and map it out. And I'm really sorry, this is a tiny slide for those of you at the back, but I'll try and walk you through it. Essentially, I start off from the premise of where do people sit in the system and how are they self-caring? So if I was a person in the system and I thought a loved one had suffered with any memory issues, chances are I would try my best to do some research beforehand. So that might be going to websites. It might be that I go to the pharmacist and I say, what do you have available for memory? I think I'm forgetting things, what can I do differently? I might end up going to A&E acutely in distress. I might call 111 or out of hours depending on what time it is. Or I might end up at my GP practice. Chances are if you have dementia, you will probably have some other coexisting comorbidities. And hence the DES, so identifying people with those cardiovascular diseases to try and pick up patients who may have, for example, vascular dementia. If I'm doing the audit, I would have brought you in, I may have called you, I may have sent you letters, I may have invited you in. I would then try and think about how the system joins up and see, have you attended A&E before? What reports do we have? If someone's recently been discharged from hospital, I've seen letters that say patient has memory issue, GP to follow up. It doesn't say anything else. There's no responsibility in secondary care to say, you know what, we may have chosen to do a memory assessment at that point of discharge to enable that patient and their carer to be better informed and facilitate that information back in primary care. But that doesn't happen right now. And that whole process, I think, takes time. So from the point where a person is concerned to a point where a lot of the investigations are done, and arguably primary care should be doing baseline blood tests, baseline investigations as best as they can. NICE advocates also doing a chest x-ray, doing an ECG and an MSU. in preparation for some medications. Next, you'll be seen in a secondary care environment. I think colleagues in a previous setting said that the waiting times in some areas are 35 days, but other areas are 18 months, pushing to 2 years. So if I'm going to be screening 300 to 400 extra people in clinic every year, I'm already going to be pushing a lot of work towards my secondary care colleagues. What impact does it have on them and the system? They will also probably repeat a lot of the things that I've done already, but they'll also tend to go for some high-level investigations and imaging. And that will also take time. And then finally, there'll be a point, I'm not sure how long it will take in different areas, but it will take a significant portion of time for a person to be given a diagnosis, and for them at that point to then be offered treatment, and for the carers to be given support. So there's a whole pathway here from the point where a person is concerned about having a memory issue to the point where actually they're getting some level of support. And I'm thinking, what are the opportunities in the system that we could support that patient earlier on? And what are the key messages that every part of the system could give? Thinking a bit more broadly, if I just take the example of diabetes, I think if I had 5 GPs in the room and I said, for that first meeting, when you tell that person that they've got an irreversible long-term condition for the rest of their life, what does that consultation look like to you? So, and 5 of you, I guarantee, would probably lend yourselves to talking about different things. Some people may push that prescription out. Some people will say that chances are you may end up on insulin. Some people will say that you will just give an FP10 out, or some people will focus on lifestyle interventions. But if I go to the pharmacy, I'll be given a different message. If I go to the community nurses, I'll be given a different message. If I go to A&E, chances I'll be given a different message. Even across the system, we can't have a consensus statement about diabetes. But could I, as a CCG board member, try and have a consensus statement so that no matter who you see within the NHS system, there are 3 key messages that a person is given about dementia, say, or about memory loss. So those 3 key messages can be given by anybody from the receptionists up to the GP in the practice, by out-of-hours providers, by community providers. So we're trying to all work towards improving the system, as opposed to just having it in silos. And there is evidence to suggest that actually lifestyle interventions do make a difference within dementia. There is evidence to suggest that regular exercise can reduce your rate of memory loss, and actually having a good diet can also make that difference as well. But we don't have that conversation. We don't focus on nutrition per se as much as we should. And arguably, that could be the consensus statement. One of the consensus statements in a system may be that we have a conversation about nutrition. It may have an impact on dementia, but you may also have spin-off benefits in terms of cardiovascular disease risk prevention, diabetes risk prevention, obesity prevention, etc. So the impact on primary care. So up until very recently, this on the left-hand side used to be my working week. Thursdays, people ask, what did I do on Thursdays? That would be my professional development time. The red slots would be my 10-minute appointments. The yellows are my catch-up spaces. The greens are where I would do telephone encounters. The blues are where I would do home visits, and the grey is admin. At my last audit, I think I was doing anywhere between 100 to 150 letters during this time, and seeing maybe 30 to 40 patients per day. On top of seeing patients and managing that, GPs do have to do QoF, LES, the DESs, which we're talking about now, additional services, ensure you have CQC in place, information governance, etc. On top of this, please see 300 to 400 extra patients per year in your service and screen them for dementia. And even if you ask most GPs, what are the screening tools that you're using for dementia? The one thing that comes back is mini mental state, which is actually not recognized or really allowed anymore. If you do use it, you may get a bill soon from someone to say actually it's copyrighted and you have to pay somebody X, I think somebody in America who's copyrighted it, and you have to pay them a subs for it. But actually, as a part of a CCG, the practice is a member. So the practice is a member of a CCG, not the practitioner. So as a CCG, we need to be thinking about how do we upskill the whole primary care team around some of our key objectives. And I'm quite keen on upskilling the whole primary care team, so including receptionists, practice managers, admin staff, non-clinical team members, so they also feel part of the NHS and they also feel that they have a role to play in the wider system. And we're trying to work on some mini projects that what can we do around dementia for our primary care teams. Inevitably, primary care has access issues. There'll be knowledge and education defects within the system in terms of how much knowledge people have. We don't have a gypsy for dementia. We have had some colleagues who have gone on to dementia leadership programs supported by NHS London historically, who have come back and been really, really influential in terms of how we're managing it. And we're setting up a single point of referral access through colleagues who I know are at the back, the RMBS team, that will be a single referral form for all our mental health potential referrals going through the system, and that will be peer reviewed by either GPs or psychiatrists to say, actually, GP X, did you know about this signposting activity that you could refer to? You haven't done this, please consider this, and then re-refer as appropriate. So we're going to be launching that hopefully around September, October, around the same same time where perhaps practices are starting to refer quite excessively into the system. I think inevitably will have an impact on secondary care as a consequence of the DES. More people will be seen in the system. My question to secondary care is, do you want to see everybody with early onset dementia? Do you really want to follow up everyone with advanced dementia? Who is it that you really want to see? And actually, when you're sending appointments in the post for our patients, when you say that your appointment is on ward X at this time, could you do more? Could you actually offer some additional information in that referral to let them know what they should be doing in the 6 to 8 weeks before their appointment? So the patient doesn't come back to the GP and say, actually my appointment's 8 weeks away, what am I supposed to do till then? Then maybe there's some intervention, perhaps it's lifestyle, that can be offered at that moment in time so that we're all taking some responsibility in the system. There'll be an impact on potentially outpatient attendances. So could we do something with the CCG and our providers to try and mitigate some of that risk? Does secondary care need to make that diagnosis? I think at the moment it does, but I'd be keen to learn from others who've maybe done it in other areas to see actually how could you upskill primary care to make that diagnosis? If services are currently at capacity, what are CCGs and secondary care colleagues doing now to mitigate some of that risk? I think then we have to also think about the impact on patients. Waiting lists are going to go up. Patients aren't going to be seen for months, if not years at end. It may have an impact on their individual insurance premiums if they have them. How do we enable patients to self-care with mental health issues, and how do we enable them to self-care with dementia in particular? How do we make sure that for different cultures that we're sensitive to that? So some cultures actually will have they have a stigma in their heads around dementia, so they will hide it from other parts of the team. GPs are quite good, I think, at picking up some of those nuances and bringing them more to the surface. But if you look at the GP cog, it's quite a difficult one to translate into different languages if you're looking and trying to manage people in multiple different languages, as many of us in London are. What about the impact on the carer? So for that time, it's not just the patient waiting for a diagnosis, but the carer is also waiting. What are we really doing about supporting that carer in the system? And do we move to a model where we're not just diagnosing and treating, but we're trying to recognize and prevent in the system? And how do we recognize people early and then prevent them from perhaps even getting dementia in the future? I went to a talk a few months back where a neurogeriatrician said that actually the signs of dementia can start as early as 40. And that's pretty scary to most people in this room right now. It's pretty scary to me. I'm about 5 years away from that. But it's an inevitability. So what am I doing about that? I need to first reflect on me, make sure I eat better, exercise better, and start thinking about this and not just reacting when it comes. It's inevitably going to have an impact on cost. We're in a service where we have QIP savings to deliver. Mental health services are going to have efficiency savings to be made. I put UCL up because UCL's supporting in a leadership program across London where CCG colleagues are coming together, and we formed a mental health leadership network. We're trying to discuss some of these issues on LinkedIn. Oxley's are our local psychiatric trust and are working quite closely with us in terms of trying to find some innovative solutions to this. But the whole system has to react to it, and I think the DES is going to push it through. And if we just assume the DES is for primary care, we've already missed the boat on this. Now, so if I then take a step back and I just say that every contact counts, that means from receptionist up to consultant psychiatrist, we need to move to a point where perhaps we are better at having those conversations around nutrition. We're better at having those conversations around lifestyle. There is evidence to suggest that if you had a combination of this diet, which is arguably a Mediterranean diet, but if you see the portion that you have to have every day about what this looks like, it's quite a scary plate size. But that's what you have to try and aim towards. And you also have to aim towards about an hour and a half of exercise per week. It takes time, and it's quite hard, I think, in 10-minute consultations when you've already got the pressure in the system to encourage people to change their behaviors. So how do we make that easier for people? And it's difficult. There are some organizations that are thinking about clever apps to make it happen, and there are other organizations that have even come up with special technology to make it happen, and that technology could even be in the form of a food. This session has been sponsored by an organization called Nutricia, who have a product called Junaid, and I understand that their stands are I43. And that is a food which may enable you to have some of these nutrients in a bottle that allows you to drink it. But it's one of many options. And their website will have much more information about it as well. So that's probably my last slide, really. And I'd really welcome the floor to challenge me or say if I completely missed the boat on this, or what can we do as a collective around this dementia challenge. Thank you very much.
Thank you very much. Okay, well, we've got plenty of time for questions, and there's a gentleman already with his hand up.
Thank you for a very helpful talk. I'd like to ask, as a GP, to what extent would you see patient participation group being involved in educating their fellow patients, etc.? So, newsletters and the like.
I think it's really important. I was told that, I'll give you a bit more context of the practice where I work. So it's in Plumstead, it's in a deprived part of Greenwich, sits between 2 gurdwaras, 2 temples, 2 mosques, and African church. High disease prevalence in terms of cardiovascular disease. I was told I'd never get a patient reference group set up. And in part that was related to me being threatened a number of times, even when I was doing medication reviews to some of our patients. And they didn't want to engage. But we did get it set up, and so some of those same patients that were threatening initially, when we started sharing some of the outcome data that we're having when we're trying to transform the way the practice worked, they become the advocates in the community. So I completely think that, and I believe that patients are key to this. So not only having reference groups, maybe even having local champions who are patients within a practice who are knowledgeable about it, to have those newsletters, have that community feel, maybe even reignite that flame of expert patient groups around this, but also have support networks within the carers side as well. So it's not just the patient that's important here, but it's the carer as well. So I completely would back you up on that.
Yes. The person at the back, and then the lady here.
I completely concur with that gentleman. It was really, really interesting. My name's Pam Kehoe. I'm a specialist dementia nurse in Manchester and a former Admiral nurse. One of the ways that I personally have been able to overcome working alongside the GPs has been to introduce health trainers into the GP practices to actually fulfil that role that you were talking about. It's a very small program that I'm working with at the moment, but we've been extremely successful and have been, if anybody's interested, has been independently evaluated by the University of Manchester. The area that I work in is very culturally diverse as well, and we've had to work in quite an innovative way, as you quite rightly say, to actually hook people in and become interested in getting an early diagnosis and pre-diagnosis support as well for family carers. I'd be very interested to speak to you if that's okay later.
Yeah, no.
Thank you.
Welcome that. And I think health trainers are key, and I came across health trainers first when I started working with public health. And then someone said to me, so what is it that public health really do in the system other than give us lots of data and tell us that we need to tell everyone to stop smoking? But actually they do a huge amount, and it's quite unrecognised. And now that we've lost them in a way to local authority, we kind of miss that input. But they do huge amounts of motivational interviewing, free training, and I would encourage all receptionists in practices to take up some of that training if they could, be that on smoking cessation. Not that they would ever have to do it, but there's a massive opportunity in the waiting area or on the telephone or at screening assessments that you can enable the team as a collective to work towards a collective agenda. Happy to catch up.
Thank you. Lady there, and then...
Hi, I'm Anna from Alzheimer's Society. I am very inspired by what you say, and I think it sets a really useful model, but I think one of the issues that we come up against as an organisation with this is that kind of your presentation presumes a positive attitude towards diagnosis of dementia, whereas I find continually still a lot of barriers and a lot of ambivalence towards dementia, and I think one of my concerns is that a lot of practices just won't take up the DES at all because they see it as too difficult to implement, or that they don't believe that there are enough benefits to a diagnosis of dementia to make it worthwhile. So what would you say we can do to change that professional attitude?
It's really hard. That hearts and minds bit is very, very difficult. I think some people are driven by money. Some people are driven by the need and the want to do good. But arguably, if we start implementing things like this now, there will be both access improvements, efficiency savings, and other system improvements that if you really mapped it out, you could see. I think the system has to think that actually the DES exists, and that's something that primary care is going to be focused on. What is it that we enable in the rest of the system to start talking the same language? So with secondary care, we have sequins, and this could very easily be an adapted sequin. So if you're in A&E, you have to do that screening if you're discharging. If you fulfill that criterion at the point of discharge, no matter what ward you're on, you have to have that screening. It'll start facilitating it. The thing, I think, the feedback I've often heard is that once we've given them that diagnosis, what then? So, and so what are we supposed to do? It's a massive thing to be told if you're 60 years old, you've got dementia. The system and media and everything in the system doesn't portray that to be a good thing. And arguably, maybe decades ago, diabetes or cancer or even HIV was presumed to be the same. But organizations such as Alzheimer's, who have done such amazing work in this, that change will come. But we've just got to make it happen. And we can't just keep ignoring it and say it will come eventually. But arguably, how many of us in this room are going to have dementia at some point in our lives? If we don't sort it now, we're only risking our own future state. So we do have to think about it in that regard. It has to be an emotive statement, though.
Absolutely. Lady at the front.
Thank you. Christine Gillum, Dementia Pathfinders, formerly Dementia UK. It's not really a question, it's more to flag up the Evidemi D project that was run by UCL and funded by the Department of Health. The project has now come to an end. It was about managing and detection of dementia in primary care, and they've produced a training package that is now freely available as it was sponsored by the Department of Health. So if you're interested in other screening tools other than the MMSE, it's all there, freely available.
Thank you. And I think we're kind of advocating either the GP COG or the TOIM, so the Test Your Memory test in Greenwich, and GP COGs on patient.co.uk, but that would also really, really be helpful. Thank you.
Good. Okay, we've got time for one more question, if anybody's got a burning issue.
It's really okay if you don't.
Okay, well then I guess you're all ready for lunch. Can I thank our speaker again, please? And